Good morning, everybody. We're going to get started in just a minute. Just waiting for a few more people to join us. All right. Looks like I don't see any more stragglers, so we're going to go ahead and kick this off. Thank you, everybody, for joining us today. For those of you that do not know me, my name is Chrissy Magnotta. I'm the Director of Client Engagement here at Katz Pierz. Our presenter today is going to be Katz Pierz's very own Lenny Katz.
Morning.
Thank you again for joining us for our webinar today, Take Control Benefit Financing for a Changing World. Just a few housekeeping items. Everybody is on mute. If you do have a question, please feel free to type that into the question chat box, and we will do our best to answer those questions, most likely at the end of the presentation, but please feel free to throw those in whenever it pops into your mind. For those of you that do not know us, just a quick overview. Katz Pierz is an independent brokerage firm based out of Cherry Hill, New Jersey. We've been in business for over 30 years. We have a national backing with our partners, United Benefit Advisors, which really allow us to have, a national reach while being able to maintain our independence. A big focus for us over the last, 30 plus years has really been our service model. It's important to point out that no matter the size, we work with all size groups. So no matter the size, whether you have 10 employees up to 3,000 employees, we deliver the same service to you. We really look at our service model as 5 different areas. The first one really being the foundation, which is advocacy. Advocacy, as you understand, in a world where benefits can become very confusing for employees, advocacy is very important. So whether it be employees calling in with questions about in-network doctors, trying to get pre-certifications or pre-auths, right down to fighting the battles directly with the carriers in regard to billing and things like that. Employee education and engagement, you can find the best financing model or the best funding model, but without that education for employees, benefits can be very, very confusing. So it's very important for us not only to properly engage and communicate with employees during open enrollment, but throughout the year as well. Again, benefits are very cumbersome, and for some people, compliance is one of the areas that most people can become very overwhelmed with. So we do our best in making sure that you're up to date with all new regulations, staying compliant within your benefit programs, and just understanding responsibilities as employers. Efficiency and technology, there's a few different aspects to this, whether it be delivering an online benefit enrollment system, doing virtual meetings, especially in the world that we're living in today, right down to streamlining benefit communications, handling enrollments and terminations for all of our clients. And last but not least is cost containment. Once you find that perfect benefit model, that financing model for you, it really needs to be supported by the right cost containment programs. We're not going to get into that too much today. If we have time, we might touch on it at the end. But what's really important to understand is this is a continuation of the conversation we're going to have today after you really understand your goals as an organization and the best financing model for you. So with that being said, we're just going to lead right into our presentation. I'm going to kick it over to Lenny. I'm going to be turning off my camera, so I just wanted everybody to see me and say hello to everybody. It's always nice to put a face to a name. I believe Lenny's going to be doing the same, so you guys can focus on our presentation. So without further ado, all you, Lenny.
Hi, hey, thank you, Chrissy. Good morning, everyone. Thanks for joining us. I know insurance isn't always the most exciting thing on everyone's plate, but the amount of money that we're all spending and the importance of providing good benefits to attract and retain employees is paramount to every company's success. So I'm really hoping you get some good takeaways from this. Um, when we look at financing models and we look at taking control of our healthcare business, and make no mistake, you do have a healthcare business when you look at how much money you spend on healthcare every year. Now, we look at it in a 7-step process, really. First, select the right partner, and obviously, we hope you select us. But if not, select somebody that provides you with forward thinking and resources to support whatever decisions you make. Secondly, determine what the best way is to finance your plan, and that's what we're going to focus on today. Then develop a multi-year cost containment strategy, communicate and teach your members about how the program works, provide responsive advocacy and resources, track and measure performance, and then make adjustments and innovate. So the first question really becomes, why is this important? Why do I really care about the financing model? Most of the folks on the call today are probably already still in a fully insured program. And if you simply extrapolate out renewals over the next 10 years, and this hypothetical example is $1 million in premium in year one, even if you get a modest 7% increase over the next 10 years, that's a $13 million, almost a $14 million spend over the next 10 years just to sustain a health insurance program. And you can see if in fact you maintain a 12% spend, that's about a $17 million spending. So the question really becomes, is this sustainable? And clearly, if it is sustainable for your business, then by all means, stay with fully insured. And it really is the best way for you to go. So a few years back, as we all know, the Affordable Care Act was passed, and a lot of us believed, a lot of us hoped that it would bring some relief to this premium escalation that we deal with every year. But in fact, the incentives built into the Affordable Care Act for the carriers, and the Affordable Care Act clearly brought some really good protections for consumers. And we really like what has happened on the consumer side. On the carrier side, every carrier has to pay out 85 cents in claims on every dollar they take in premium. So that gives them 15% to run their business and create some profit for their shareholders. There's no incentive whatsoever for a carrier to control the cost of care, because as that 15% grows and grows and grows over time, there's more dollars going into their shareholder equity. Just a quick slide, Aetna's stock performance, and I could show you the same thing for the Blues, and I could show you the same thing for Cigna and United Healthcare. None of the insurance carriers are really feeling any pain as we've been going through healthcare reform. What we're going to look at today, and don't be alarmed by this, we're not going to jump into every one of these items in depth, but we really are going to talk about financing your healthcare, your program, and what the different platforms are. On the far left, you've got a fully insured plan. The most important thing about a fully insured plan is that 100% of the risk is transferred to a third party, which is, of course, the insurance company. And all the employer is responsible to do is facilitate the funds, is pay premiums. On the far right, this is what the Mobil Oils of the world do. They self-fund, they take complete control over their program. They provide their own administrative services. They really don't even provide any stop loss, because there's so many people insured that the law of large numbers gives them significant predictability on cost. Well, that's none of our folks, and that's nobody on this call, I don't think. So we're really going to focus on some of the items in between. The first thing we always like to point out is, how does fully insured work? Well, we all know you pay your premium. If the premiums that you paid exceed the amount of claims that were incurred, you don't get any money back. If on the flip side, your claims exceed the amount of premium paid, Again, you're not asked to pay more money, but you get a nice surprise come renewal time where the carrier looks to recoup some of the losses from the previous year. A lot of our clients feel like this when it comes to fully insured programs. They get a surprise roughly 60 days before their renewal, and then they have to quickly react to that and make a change. And that's typically just for a 12-month solution. It really isn't anything long-term. Several years back, we started working with a lot of clients, and you may already be doing this in your business, where you move to a high deductible health plan, whether it's a qualified plan or simply a hybrid model. By doing so, we lower the fixed premium cost versus a traditional plan. Then the employer uses some type of a financing model to redirect that savings to help employees with that additional risk, whether we're using a health reimbursement arrangement where the employer promises to reimburse some or all of the deductible or coinsurance, or if we're using a health savings account where the employer is actually making tax-free contributions to the employee's health savings account, and then that money is actually owned by the employee. Both of these methods are very successful, but neither of these methods really get the employer off of the wheel because we're not really impacting or changing the underlying financial funding model. It's still that fully insured model. This is one of the things I'm going to try to do as we move forward, which is kind of summarize pros and cons. So clearly, fully insured is very, very popular, mainly because it's the easy button. It provides an employer and employees with predictable one-year cash flow. There's very, very little risk to the employer other than paying premiums. And perhaps if you adopt an HRA, you have some risk there in terms of your utilization. And you get carrier name recognition, which is to some degree important. You know, in our area, you see billboards for Independence Blue Cross everywhere. And that certainly gives our employees and their families a sense of security knowing that they have that blue card. But on the flip side, a fully insured program provides a lot of premium volatility. There's little or no actionable data, so you really don't know what's going on inside of your plan to then affect savings. The employer has little or no design flexibility. The insurance company tells you what programs are available. You pick the one that best suits your needs, but you really have very little opportunity to modify those plans. The insurance carrier profits from prescription rebates, and that's something we're going to talk about a little later on. But behind the scenes, there's something called a PBM, or pharmacy benefit manager. That manager aggregates discounts or rebates from different manufacturers. And when you're in a fully insured program, that's a profit center for the insurance carrier. The other biggest negative that I think that most of you will agree with having a fully insured program, if you get a big increase and now it's time to maybe move to a different carrier or even a different program within that carrier, it causes a lot of potential employee disruption, especially if you're moving to a different carrier and you're moving to a different formulary. Employees get very uneasy and it does cause disruption. Those programs are also subject to state mandates and taxes, and as we'll see moving forward, there's a way to eliminate or reduce some of that by moving to some of these other models. So that's kind of the background on what fully insured does, and what we really want to do now is kind of look forward and see where we can go to get off of that wheel. We're going to talk about self-funding. Self-funding really means a lot of different things, and it's based on the size of your group and which of these models you select. And we're going to get into these models in some detail. But every self-funded plan does have some things in common. The first thing is that the experience for the employee is exactly the same as the experience the employee has today with a fully insured program. They get an ID card, they have network access to providers, assuming you're using a network. There are ways to eliminate networks. We're not really going to get into that today. They're going to have a pharmacy ID card so that when they walk into the pharmacist, they can present their card and get their medication. Plan designs are similar to what you have in the fully insured marketplace: deductibles, co-insurance, maximum out-of-pockets, co-pays. And every one of the models we're about to look at can be still paired with a health reimbursement arrangement or a health savings account, or both. Conceptually, a self-insured or a self-funded program, an employer will assume some risk with the expectation of reward. So they're hoping that their claims will be low. They recognize the claims won't be low every year, so there might be some years where they may lose the bet, but over the long run, they typically win the bet. A third-party administrator is hired. This is called a TPA, and that's an independent organization that's hired to pay claims and manage eligibility. Some insurance carriers also provide administrative services, and you can buy them under what's called an administrative services only contract, or ASO. Employer will then buy stop loss insurance to protect against high claimants and a lot of claims from the group in general. Since there's various components, and we're going to look at those, each one can be analyzed and managed separately. So if we're with Aetna as our network, and Aetna loses some key hospitals in our geography, we can unplug Aetna and perhaps plug in the Blues or plug in Cigna if they have the network access that we're looking for. But in a self-funded program, you have the ability to unbundle all the different components we're going to look at. Self-funding is typically governed by ERISA, which means that we are able to avoid some state mandated benefits. And in New Jersey, those can be a little onerous, and they do add some cost to the programs that we can avoid by moving over to self-funding. Smaller employers commonly adopt a level funded program. Level funding is a form of self-insurance, self-funding, which we'll talk about in a few minutes, that reduces the employer's risk and does provide the employer with the ability to capture some rewards in a good year with low claims. Now, we just talked about this quickly: plan administration, stop loss insurance, provider network, pharmacy benefit manager, plan design. When you move into a self-funded model, for the most part, you have the ability to design whatever program you want. So if you want to have a zero copay for primary care and a $200 copay for specialty, you can write your plan document that way, as long as it falls within federal guidelines and the ERISA oversight. And of course, once you get into a program like this, you do have the ability to use some of the cost containment programs that Chrissy alluded to earlier, and those really have an impact on providing better care and access for your members, lowering their cost, and ultimately lowering the cost to the program. One of the most important concepts that we have to understand is, what is specific stop loss protection? So in a self-funded plan, and this is true with all the programs we're about to talk about, the employer pays what we call the small claims out of their general ledger, out of their claim fund if they're level funded, or out of their general ledger if it's a purely standalone self-funded program. So we buy specific stop loss to protect the plan, the employer, from large claims from any one individual. The example we're looking at is a $25,000 specific stop loss. So as you can see, employee A only spent $5,000 in claims that year, so those were all paid by the plan. Employee B, on the other hand, looks like that employee or that member could have been a dependent, spent looks like about $27,000. Well, because of the stop loss level, the employer is only responsible for the first $25,000. Anything over the specific stop loss is paid by the insurance policy, and we pay a premium for that policy. The second level of coverage that we buy is something called aggregate stop loss insurance. This protects the employer from excessive claims across all members that are under that specific. So the example I like to talk about, in fact, this was used by one of my clients at an open enrollment meeting. So we have about 100 employees and there's about 175 what we call belly buttons when you include the dependents that were insured. If the entire company and all the dependents are at the same picnic and they all eat the same bad potato salad and they all wind up in the hospital with $25,000 or more of claims, that could cost the employer over $4 million in charges under the specific stop loss. Obviously, that's not what we want. And most employers wouldn't enter into an agreement or a contract if that were the case. So instead, the underwriter will figure out what our expected claims are going to be based on our demographics. And once we're into it, what last year's claims experience is. And they'll set a point at which the employer is no longer responsible for claims. That's called the aggregate attachment point. Since there's a little bit of guesswork involved in what the expected claims are, most underwriters put in what's called a risk corridor, and typically that's about 125% of expected. So in this example, we might have a $25,000 specific stop loss, meaning the employer pays the first $25,000 of claims incurred by anyone insured by the policy. But once the claims of the entire group reach the aggregate attachment point, might be $1 million, anything over that is paid by the stop loss carrier. So the employer doesn't have to worry about a really, really bad year across the board, nor does the employer have to worry about a runaway claim for one particular employee because they're protected by the stop loss program, the specific stop loss. The first model we're going to look at is level funding. In a level funded program, and this works very, very similarly to a fully insured program. In a level funded program, that employer still pays $1 in premium every month. Roughly 25 cents of the dollar goes to pay administrative fees. Another 25 cents goes to buy stop loss insurance. About 10 cents goes to buy what's called terminal insurance, which essentially pays claims should you leave the program. And then the rest of the dollar goes into a claim fund that is set aside to pay claims. So now the employees start incurring claims. They go to the doctor, they go to the hospital, they go to the pharmacy. At the end of the year, if claims paid out of your claim fund are less than the amount of money contributed to the claim fund, the employer has a reward. The employer gets some money back, some or all of that money back. And that depends on which model you jump into and who the carrier or TPA is or the model that you purchased. Remember that when we're looking at the claim fund, only claims under that specific stop loss level are charged against the claim fund. So even though the employer is paying the same amount of money every month, behind the scenes, the carrier is still applying a specific stop loss level. Might be $20,000. Somebody has a premature baby, that's a very, very expensive claim. Could be a $200,000 claim. Only $20,000 would be charged against the stop loss fund, against the claim fund in this example. And so it won't kill the claim fund with one specific claim that happened. If claims exceed the claim fund, you're not asked to pay more money. That is what you bought insurance for. But again, typically, just like a fully insured program, that excess will try to be recouped in year 2 and year 3 by the carrier. So you might see a little bit more of an increase the following year. There's 2 different models that we work with. One is a level funded model that's supported by an insurance carrier. And you can buy this from Aetna, You can buy it from Cigna. You can buy it from United Healthcare. There's a couple of blue programs that are doing it as well. And then there's something called the consortium model. The consortium model, as you can see, is a lot more flexible. You can choose your third-party administrator. The cost of administration is a lot less than the carrier model. And most importantly, the consortium model has a shared risk or a pooled stop-loss policy. And so when you're in the consortium model and you have a bad year, the consortium policy, the stop-loss policy, helps reduce volatility. When you're in the carrier model, as I just explained a moment ago, and you have a really, really bad year, your claims kind of stand alone. There's a little bit of pooling, but your claims really stand alone. And your premium charge for the next year could force you off of that plan because it's excessive. The other thing that's interesting is when you look down at the last line, the renewal increase applied equally across all elements of the plan. So if you're in a level funded program with Aetna or with Cigna, and you get a 19% premium increase, that 19% will be applied to every one of those components we just looked at: administration, stop loss, claim fund. When you're in the consortium model and you get a 19% increase, it might only be, and it will only be applied to the stop loss premium. There'll be a different number applied to your claim fund and little or no increase to your administrative fees. I mentioned earlier, I like to use pros and cons. So when we look at the pros and cons of the carrier model, like a fully insured model, it gives you predictable one-year cash flow, very, very, very little risk to the employer other than whatever surplus might be returned. You still have that carrier recognition. You do get more data. You do get more data than you get when you're in a fully insured program. So it does help you understand what's going on and help you perhaps try to tweak some of the items to reduce cost or improve benefits, or both. And again, it's fairly easy to manage. However, as I just mentioned, it does still have some volatility year over year. Because you're with the carrier plan silo model, you have very little control over plan design or flexibility. You also have no network flexibility. If you buy this from Aetna, it's Aetna's network. If you buy this from Cigna, it's Cigna network. Typically, these programs don't provide any surplus if you decide to leave. So in a year that you leave and maybe you move to a different model and you do have a cash surplus there, you're going to be walking away from it. These models also are still a profit center for the prescription rebates. And in many of these models, the carrier keeps a portion of the surplus in the year in which you have a surplus. Typically, you're going to see the carrier keep about 50% of that surplus, and you get back about 50% of that surplus. The consortium model, as we looked at a few minutes ago, reduces a lot of that volatility. It still brings all the same pros that you get with the carrier model. You lose the name recognition, although you're still going to have Aetna's logo on your card if Aetna is the network that you choose. You still have Cigna's logo on the card if you choose Cigna. You do gain control of those rebates, which is important, because they could be several $1,000s or multiple $1,000s throughout the year, and that comes back to the employer in this model. You still have some of the cons in that sometimes you have to worry about the terminal liability if you leave. You're typically not funding for that. This program does have an option to purchase terminal protection, so you have to be cognizant of that, whether you want it. And it still has a higher expense load than a true or a standalone self-funded program. So now let's look at standalone self-funding or true self-funding. We already talked about fully insured and we already talked about level funding, and in both of those programs you pay your dollar and you might get some money back if you're in a level funded program. You get nothing back if you're in a fully insured program. But in a self-funded program, it's pay as you go. So essentially, you're going to pay about 25% of what you would have paid in a fully insured model towards administrative fees. That's hiring that TPA or that administrative only services contract from an insurance carrier. And then the rest of that 25% typically will go to buy that specific stop loss insurance we discussed and that aggregate insurance. So once you have these two things in place, now you're actually just paying all those small claims as they come in. You might have a month in which you only pay 25% of what you would have paid. You might have another month where you pay a little more. The following month, you might pay a little bit more. And the following month, you might pay a lot less again. So in a true self-funded model, you really are paying as you go. But remember, I mentioned earlier that since the underwriter doesn't exactly know where your claims are going to fall, and they always leave themselves a margin of error, there is a possibility that you could pay more in any given month than you paid if you were fully insured. And if you have a really bad year, you might also wind up paying a little bit more than you would have paid had you been in that fully insured or that level funded model. But as we said earlier, an employer moves into this with the assumption that there might be a year or two where they lose, but most years in this long-term solution, they are going to win and wind up paying less than the fully insured program. I like to use graphics, and I think this is a great way to look at it. So in a fully insured program, you pay $1 million worth of premium on your employees. You move to a self-funded platform. We hire a third-party administrator, costs us about $60,000 in administrative fees. We then buy stop loss insurance, that specific that we spoke about, and again, that aggregate. That premium in this example might be $250,000. So if nothing else happens in the rest of the year and you have 0 claims, you paid $60,000 for an administrator, you paid $250,000 for insurance, and that's all you paid. But of course, that's ridiculous. We're gonna have claims. The underwriter looks at our experience, looks at our demographics, looks at our area, looks at our network, and decides that they believe we're going to have about $585,000 in claims over the next 12 months. The underwriter also says, as we discussed before, we're not really sure what your claims are going to be, so we're going to create a margin of error for ourselves. So we move into this model, and if we actually hit what the underwriter suspects we are going to pay in expected claims, we wind up paying about $895,000 over the next 12 months versus the $1 million we would have paid if we were fully insured. Of course, if the underwriter is wrong, we know going in that our maximum cost is $1,047,500. So we're never going to move into a model where there's no cap on the back end, where the employer is in a situation where they have no idea what they could potentially spend. So in this model, we know where our maximum is, we know what our monthly or what our expected is, and we know what our fixed costs are as well. And we have many, many employers who don't even spend what is the expected number. And again, that's going to change year over year. But the magic of this model really happens in year 2 and moving forward. So let's say you're in that fully insured model and you have an average claim year. You know, it's not really on fire. You didn't really have a lot of claims that exceeded whatever the pooling charges were, but you did a little worse than average. And you're presented with a 15% renewal from Aetna, Horizon, whoever your carrier might be. So in year 2, your fixed cost increase is $150,000. And your total cost now goes to $1,150,000. Well, what happens with that similar scenario in a self-funded model? Third-party administrator fees are typically guaranteed for 2 years, so your admin fee doesn't go up. And even in years once the rate guarantee goes away, it usually goes up by a cost of living increase, which is very, very modest. let's say the underwriter still gives you that same 15% increase on your $250,000 premium. So that goes to 287.5. But remember earlier we talked about how these components operate separately. Most of the time when you get a 15% increase on your premium, you're not going to see that same 15% increase on your expected claims and your aggregate exposure. In this example, it might only be 7%. So expected claims go up to 625,950. And yes, that does push the aggregate attachment point up as well. So in year 2, with the fully insured model, you took a premium increase of $150,000 with no hope of relief for the next 12 months. In the self-funded model, you took a premium increase, a fixed cost increase of $37,500. Expected claims are potentially going up, but they might not. So in year 2, if claims come in at expected, you spend $973,450 against $1,150,000. And in a worst case scenario, you're capped at $1,136,000, again, against that $1,150,000. It's important to note that even though expected claims went up, many times in year 2, that actual claims, the actual spending, might be even less than the first year expected. So you really could spend $60,000 on admin fee, $287,000 on insurance premium, and your claims in year 2 might actually be $540,000. And that happens often. Looking at the 10-year extrapolation of the model we just looked at, you can see how over time the self-funded model really yields great results over fully insured. And it really gives you that sustainability that you're looking for that you can't find or that doesn't come with a fully insured model without significant disruption. And again, when I say significant disruption, I'm talking about shifting more costs to your employees, changing networks, changing carriers. In a self-funded model, you can tweak those things as you need to, but you don't have to make wholesale changes year over year. So let's look at pros and cons again. Under the self-funded standalone model, you improve your cash flow because you're paying claims as you go. You're not giving the same dollar every single month. You buy stop-loss insurance to limit exposure. We do get some really good granular data. And yes, it's very important in these programs that you have a HIPAA privacy officer, and that privacy officer builds significant walls between the hiring function and the claims data, because when you're in this, you do have access to what's called protected health information. Some employers don't want to see names and they don't want to do that. Other employers want to see that data because they want to make sure that those claims really are happening from their population. It's a good way to audit your claims. But again, privacy is of paramount importance here. Cost containment programs do have an impact on your spending. You take out carrier profits again. In a standalone model, you have the ability to go out and shop the stop-loss policy. You have the ability to change different pharmacy benefit managers to those that provide you with better rebates, because in this program, you do own the rebates. And not only rebates, but lower cost structure when your employees go into pharmacies to pick up their drugs and get their medications. And again, you have complete flexibility in plan design and network selection. On the negative side, it is inconsistent monthly spending. You might have a high month of spending, you might have a very low month of spending, but versus the other models we looked at, which are very consistent, this will be inconsistent spending. You have the potential of lasers on high claimants. This is something we haven't mentioned before. I threw in a very quick definition of what a laser is on the bottom. It's like buying fire insurance on a house that's already on fire. What that means is you go to renew in year 2. The underwriter knows you might have an ongoing dialysis claim that might cost $125,000 in the next 12 months. but you only have a $25,000 specific stop loss, meaning that's all you're, as an employer, is responsible for. A laser would mean that the underwriter might come back to you with a renewal and say, well, we're going to continue to have that $25,000 specific stop loss protection on every member of your group, except that one member that has the dialysis, and they might move your specific on that one person up to the $125,000 level or the $100,000 level. So that is one of the risks that come along with standalone self-funding. There's definitely more engagement when you get into a self-funded program at the employer level. Again, as we mentioned earlier, at the member level, it works just like a fully insured plan, but there is more oversight required. There's more moving parts. And so along with your consultant, with your advisor, there's more things that have to be managed. The employer is the plan fiduciary. Plan document management is critical because when you buy stop loss insurance, the stop loss carrier will pay claims over the stop loss levels based on your plan document. So it's very important that your plan document says how people are eligible, when they're eligible, and what claims are paid and to what level they're paid. Standalone self-funding can be very, very volatile. As we just mentioned, there's the potential of lasers. You're also standing alone in the stop loss market if you're only a $250,000 premium. And last year, your stop loss carrier paid out $500,000 in reimbursements. That stop loss carrier may not look upon your renewal very favorably. You may have to go out and shop for another vendor, another stop loss reinsurer to give you a favorable price. So because of this volatility, we believe that the best way to go for a mid-size, small to mid-size employer that wants to step into standalone funding is using a benefit captive because it reduces significantly that volatility. The captive reduces volatility versus traditional stop loss insurance. It provides security and community so that the members can focus on cost containment. Similar to the other model we just looked at, the employer still retains complete control and flexibility over plan design, administration, network, pharmacy, and cost containment programs. So how does the captive reduce volatility? Well, the employer receives a stop loss policy from the stop loss carrier partner. We happen to have one particular captive that we like. We've vetted many captives, and there are different models out there. The one that we like the most is through a captive manager called Pareto. Pareto has about 1,000 members that share one stop loss policy. Each policy is proportionately given to each member, so each member has their own policy, but the risk is pooled with all the other members. Each employer is actually an owner of the captive. As I mentioned a moment ago, the policy does convert from an individual product to a pooled product, and that pooling provides a risk sharing that you don't get when you're in a standalone self-funded program. Back to my pros and cons. You still retain all the features that you get with a standalone self-funded program. You improve cash flow. But because the captive, and again, I'm pointing particularly here at Pareto, and one of the things we do at Katz Pierz is we're constantly evaluating captives that are in the market to make sure we are with the one that brings the most value to our clients. Pareto's program provides no lasers on renewal. It provides the best-in-class contract provisions that are available. There's pooling of the renewal action, as we mentioned before, and the policy has achieved what we call critical mass. The premium is well over $400 million. So now if your particular group has a bad year, you're not standing in front of your stop loss carrier with $250,000 of premium against $400,000 of claims. You're now part of a risk pool that has $400 million in premium. I mentioned again, it's member owned. Because of the amount of leverage that's brought to the marketplace with the number of people that are enrolled in the program, I think there's about 300,000 belly buttons that are actually covered today. It gives the captive the ability to bring some proprietary vendor relationships on the cost containment side, and that really helps anybody that's in it, all the members, with cost containment. There's also an ERISA legal firm that backs the captive called the FIA Group. They become co-fiduciary and they do all that plan document review that we spoke about before. Not only do you get actionable data, like I mentioned earlier, but they also provide a claims analytic tool to help you effect those deep dives into your data. And similar to the other programs, you do have network flexibility, carrier, and plan design as well. Similar to other stop loss programs, similar to other fully insured, self-funded programs, you still have inconsistent spending. There is a requirement that the employer still has to pay a lot more attention than in level funding. And in this particular model with Pareto, they do have member meetings. Members go share best practices. It's a very dynamic environment where HR people and CFO level people share what they're doing with each other, and it's very beneficial. The captive is selective. The captive is not going to let somebody that's already on fire, meaning there's a lot of very high ongoing claimants, into the captive. So we've actually had clients that really wanted to get in, and they had to wait a year or two until things calmed down. Once you're in, though, they're not asked to leave as long as they're doing what's required of a member, which is attending the meetings and trying to do things to control costs. As I mentioned earlier, it's a bunch of like-minded employers. A lot of the onus on the employer with fiduciary and plan document management goes away because of the existence of the FIA Group. And there is a capital expenditure required for each member to join, and that is additional expense. But in the Pareto model, if you leave the captive, that capital expenditure is returned to you. So, I've been doing these charts, and I know this is a little bit busy, and I apologize, but I think it's important that you look at across the board the full spectrum of what we just reviewed. Fully insured, level funded under a carrier model. Both of these are easy. Both of these are controlled by the carrier. Both of these give you guaranteed monthly cost, but both of these are very volatile. Moving into a level funded model with a consortium, because of the nature of the stop loss policy, you do reduce a lot of volatility. You also gain more flexibility in network, in plan design, in administration, in pharmacy management, and you do participate in some of those rebates. When you move into self-funding, and we really look at a group of 75 up to 500. And by the way, there are groups in the captive that have more than 500 employees, but we don't really want you to start looking at a standalone self-funded program with less than 500 employees. If you have less than 500 employees, we really believe you want to be in the captive model because it reduces significantly the volatility we just discussed earlier, but still gives you all the rewards of good claims, flexibility in plan design, network choice, and all those other things we talked about before, rebates as well. We have about 10 minutes left. I'm going to move on to what we like to think of as the Holy Grail. And I'm going to throw this back over to Chrissy, because now that you've switched over to a self-funded model, that's wonderful. You now have the tools in place, but it really doesn't answer all the questions, because when you look at your spending in a self-funded program, even a level funded program with the consortium, again, roughly 25 to 30% of your cost is fixed. 70% of your cost year over year is really what your small claims are and how you control those small claims. And that's where we get into cost containment. Chrissy, would you like to take us to the end?
Sure. Thanks, Lenny.
Thank you.
So yeah, like Lenny's explaining, really when you're moving away from fully insured, it's about getting back that control, really getting some actionable data, being able to take a look under the hood at what is happening within your organization. A lot of times when you're looking at cost containment programs and you're in that fully insured model, you're really only helping the carrier. Yes, of course, you can certainly, bring a program to the employees. I'm sure they'll be very appreciative that you put in a wellness program or something of the sort. However, when you're really trying to control those costs, when you're looking at cost containment, we're really looking at all of those claims, those small claims that could eventually turn into some pretty big claims in the future. So Lenny, yeah, if you want to, there you go. So when we're looking at when we're looking at cost containment, we really look at it in a few different phases. We always suggest that our clients walk before they run. We never expect anybody to jump headfirst into a full-blown program that they haven't necessarily been prepared for. So I'm not going to get into all of these, but some of these are things that Lenny already touched on. Selecting the right PBM, examining different captives and different types of consortiums to be able to help pull some of that risk or help reduce some of that volatility. Really being able to measure performance, using those dashboards, being able to look at the data, understand where those gaps in cares are. Low-hanging fruit is just kind of a tongue-in-cheek way of putting, some of these easier programs, right? Some of these programs may be free. They might be just a little bit easier to implement. It may not include a ton of employee engagement. But, a few things to point out here, telemedicine is huge. We're seeing a very big jump in utilization with telemedicine, given the past, with everything we're going through with the COVID-19 pandemic. But historically speaking, telemedicine is one of the most underutilized programs that an employer puts in for their employees. And when you think about it as a cost spending perspective, you can pay $40 for a telemedicine visit, or you can pay, $100, $200, $300 for an urgent care visit. Sometimes even the emergency room, very often we end up in the emergency room, and those costs can be, quite high. So just educating employees on the different programs, providing that employee advocacy, letting employees know that they can be better healthcare consumers and they do have options, having that proactive COBRA outreach. The more engagement, or the programs that take a little bit more to install, that really require employees to engage and employers to adopt and really encourage employees to jump into, are going to be, one of my favorite is care coordination programs. There's so much out there with technology and different vendors to help employees find lower cost providers. And that's really what it's all about, especially if you're working within some of those high deductible plans. As we all know, an MRI could cost $5,000 at one location and $800 at another. Same test, same MRI, same results, just a higher price tag. Employee wellness programs, a lot of times it's a little bit difficult to really see the ROI within an employee wellness program, especially if you're in a fully insured program. However, with employee wellness programs, you can really decipher how you want to encourage some behaviors. So if you're doing a point system, encouraging employees to go and get their preventative visits done, whether that be annual, whether it be, mammograms, whatever you can do to encourage employees to just stay on top of their health. Tobacco cessation programs, encouraging employees to enter into a program to, get them to quit smoking. Obviously, we all know that is something that is not great for our health. So if we can encourage employees to just change some of their behaviors into healthier behaviors, that's what's going to drive a lot of those claims down. Cancer care programs is a big thing. A lot of people don't realize this, but there actually is a high number of diagnoses out there that are misdiagnosed. We hear of situations where employees are diagnosed with cancer, and then after going through treatment, find out they actually didn't even have cancer. So putting in programs with nurse advocates in the background to help employees not only mitigate some of those stressors, right? Obviously, a diagnosis like that can be very stressful for an employee, but helping guide them to the right care, to really understand what their treatment looks like and what their diagnosis looks like, and take a holistic approach, really does wonders when it comes to not only helping the employee morale, but really driving down some of those claims. I had mentioned earlier that cost containment, really is a discussion that comes after the funding discussion. Once you've made that jump into really deciding what's going to work best for your organization based on goals, based on demographics, based on just industry benchmarking, the cost containment programs are really what's going to help you control some of those costs and really help the employees appreciate the benefits that they have and help understand them and help make them better healthcare consumers. So I'm not seeing any questions popping up, but I guess I'm just going to have a leading the witness question for you, Lenny. So when employers are looking at their benefit plans, and they're really trying to understand what's going to be sustainable for them, in your opinion, what would be a program that you would suggest for a long-term goal in sustaining costs, keeping them low, being able to provide benefits for their employees without having to water them down and really, up those costs?
It's really a function of the size of the group and certainly the risk tolerance within the management team of the group, the executive leadership team. If the group is under 75 lives, insured lives, really the level funded program with the consortium brings the most control, the least amount of volatility, and the most flexibility to the employer and the employees with the program. And it gives them a long-term solution so that they're not making that carrier jump, every 2 to 3 years. Over 75 lives to 500, we really like the captive approach. We've been having wonderful success with the groups moving into specifically the Pareto captive. I think our client, we have a couple clients that have been in it for about 7 years. And yeah, there's been 1 or 2 years where they've had bad years, but then they've followed those bad years with good years. And they've saved significant dollars by being in the program. One of those clients has even improved the benefits. They were one of those groups that had a high deductible and they used a health reimbursement arrangement when they were fully insured. And for the first couple years in the self-funded Pareto program, they kept that model. But after a few years, they wanted to simplify things for the employees, make it easier for them to access the care they needed. So they went back to a traditional copay plan with actually a low maximum out of pocket, no increase to the employee contributions, by the way, and it's been working very, very well. So it gives a lot of flexibility. So to answer your question, it depends on the size of the group. If you're under 20 lives and you're looking to do something to help sustain long-term plans, you're really going to be stuck in the carrier level funded model, and that's not terrible. That's still a little bit better than being fully insured. The good news in that market segment is that if you have a bad year and you get a bad renewal with that carrier level funded program, you can still go back to the fully insured market and jump into what we call an ACA or an Affordable Care Act age-based program. But again, Chrissy, it's really the size of the group.
Sure. Thank you for that. And we do have one question that I think I can address as we wrap up. Does your agency analyze your client's company and plans and help determine which plan would benefit them the most? Absolutely. Every group is different. Regardless of size, goals are going to be different for each organization. So what we do is we actually have one of the largest benchmarking surveys through our UBA partner. So we can look at how your company stacks up regionally, demographically, industry, and really we're going to sit down. We like to call ourselves consultants. We really don't get into the game of chasing down rates. It's all about what your company goals are. What do you think that you can do to sustain over the years? Because as we all know, we could run really, really well and still get an increase in our insurance. And that's just not a sustainable model, as we saw earlier. So we look at not just the benchmarking, but we're also going to sit down and really understand how your organization is run, what type of employees we're really trying to access, and determine what the best plan of action would be for your company. One more question. In general, for companies that are over 100 employees, do you recommend fully insured or self-funded? Regionally, the Northeast hasn't adopted self-funding as much as some of our other, regions. I would say that over 100 employees, absolutely. There are so many programs out there that can help you take back that control and reduce the volatility. It's not just about choosing between fully insured and a true self-funded program anymore. As we talked about, benefit captives and things like that are great programs for companies of 100 employees or more, even like Lenny had mentioned, 75 employees or more at this point, and can give you back that control, but with those guardrails of those pooled protections with stop loss and the cost containment programs and things like that. I will be following up with everybody, all attendees. I'll be sending out an email. So if there's any additional questions, if anybody wants to take a deeper dive into any of these programs, if you want us to run a complimentary benchmarking report for you guys, we are absolutely happy to do so. Lenny, did you have anything to add before we close out?
No, I just thank everybody for joining us this morning. And it doesn't really matter which model is best for your group. All those other things that we talked about earlier with advocacy and communication and education, those are really important things. And as an agency, we put just as much effort and importance on those as we do on picking the right platform, because no matter what type of plan you have, your employees need assistance. They need to learn the programs. And then once they're using it, they need help navigating those programs. So, thank everybody for joining.
Great. Thank you, Lenny. Thank you, everybody, for joining today. I hope everybody stays well and has a great rest of the week and a great weekend.
Thanks, Chrissy.
Thanks.